So looks like people are getting into the webinar, so that's really great. You can hear and see me fine. So we're going to crack on with talking about what we actually do for osteoarthritis. Good evening to everybody. My name's Jack, and I go by the name of the rheumatology physio, and have talked about osteoarthritis. A good bit. It seems to fall under my remit relatively regularly with its sort of low-grade inflammation. So that's what we're going to talk about this evening. Hopefully, give you some ideas on what we're going to do. So we're going to talk off beginning with some interventions. We're going to talk a bit about those with some detail, what we might do, what we might not do, what the sort of evidence base says about those. Then we're going to talk a little bit at the end towards decision making, and then I'm going to stick my head above the parapet and talk about what I think the hierarchy of effective treatments are. Just got a couple of people in the chat at the moment with no sound. That usually happens if you're not using a Chrome browser. So if you leave and come back in a Chrome browser with the same link, then that should fix the problem. Oh yeah. Okay, so let's crack on here. Let's get through as much of this as we can. So let's start off with exercise, which is all of our favorite interventions, I would guess. I'm going to guess most of us are physiotherapists or some kind of MSK therapist, and we've got a bit of an issue around exercise these days with regards to osteoarthritis, and that is that exercise is recommended very, very strongly in pretty much every guideline, that is released regarding osteoarthritis, regardless of the sort of location of that osteoarthritis, so regardless of where the osteoarthritis is in the body. But then relatively recently, in the last few months, we've had this Lancet review, which was published, and that gave a pretty poor reflection on how effective exercise might be for managing the symptoms of osteoarthritis and the progression of osteoarthritis as well. So what that Lancet review basically said was that while exercise provides some benefit, it probably doesn't provide any benefit over other types of treatments with regards to the symptoms and progression of osteoarthritis, which was rather disappointing, although probably not that big a surprise to many people who have tried to follow the evidence base for osteoarthritis treatments. So where the problem then becomes is the exercise providing benefit over or reaching a clinically important difference or a clinically important change for these patients? And that Lancet review would suggest potentially not. But the guidelines are all promoting us using exercise to manage the symptoms of osteoarthritis. That is a bit of a challenge. There was lots of chat across social media about why that might have been, what might have been shown with that review, what it might say, what it might not say. That is a very interesting discussion. I think there's a lot more to come out from that. The easy answer with regards to exercise is it obviously has other benefits that might be used or might be elicited through exercise, such as general health benefits, reductions in systemic inflammation, that kind of thing. Whereas actually addressing the symptoms of osteoarthritis, so if you've got osteoarthritis of the knee, actually improving those symptoms that someone has that is presenting with, that might not be that beneficial. However, if we do break it down, it does seem that if you go into some of the subgroups, the patients who have the poorest function of the joints, so range of motion, strength, that kind of thing, physical function, up and down stairs, walking, they do seem to improve more with exercise than those who have good function but pain. So we need to try and think about how we're going to separate what the symptoms are that are being presented with. So how much is there that's just purely pain related? How much of there is their function of the joint what kind of issue do we have there? And maybe it might be that those patients with low pain, poor function are going to do far better with exercise than those with high pain and good function, which of course we see regularly, and all the parts in the middle as well. So moderate pain, moderate function. So it is probably about picking our patients and making sure that we understand which ones we're applying to, and that's what I'm going to hopefully try and get at the end. Now, what types of exercise do we use? That's still out for a bit of debate as well. There's some really good work around strengthening exercise, but really what it seems to be at the moment is the patient's preference is going to pretty much be king. And activity is going to be really useful as well as exercise. So you might use general activity increases to reduce that systemic inflammation, increase general health, increase cardiovascular fitness, those kinds of improvements, as opposed to targeted exercise where really you're going to be looking at specific functions. So obviously if the patient is lacking full extension of the knee, then working on regaining full extension of the knee can take its place with specific exercises, and that would obviously be assessed on an individual basis. That seems to spread across the joints. So throughout the rest of this presentation as well, we're going to talk generally about osteoarthritis, and I'm going to mention specific joints where there's slight differences. But these results do tend to push across across all the joints of the body. So I want to move on to weight loss, and this could be a bit of a controversial topic, but it is extremely important with regards to osteoarthritis, and that happens for a few reasons. So let's dispel the myth that reducing the weight reduces the force through the joints, and so you'll be less likely to develop osteoarthritis. That's really an oversimplified way of thinking about it. What we see in patients who are overweight, particularly with abdominal fat, is this increased level of systemic inflammation, and that is what's going to cause the degradation of the joint, or increase the likelihood of developing symptoms related to osteoarthritis. So there's a bit of a difference there. So what we see when patients have a difference in BMI, and again, particularly abdominal fat, so BMI is a bit of a blunt measure, but this abdominal fat increase, the risk of developing symptomatic osteoarthritis is reduced if you are at a more normal weight, or a weight appropriate for your height, let's say. Also, if you have developed osteoarthritis, if you lose weight at that point, then the progression of osteoarthritis, both with symptoms and structural change, is reduced. And if you have symptoms and you lose weight, then they will also be reduced. Now, what's interesting here is an interesting phenomenon where even patients who are of a normal weight, if they lose some weight, then their progression and their symptoms also are reduced. Now, that does bring in a bit of a controversy as to who do you want to lose weight. If someone is of a normal weight, do you really want them to lose particular amounts of weight? But they still see benefits from weight loss. So we're really seeing this as probably the most effective intervention. That's not to say it's the easiest intervention. We know that weight loss is extremely difficult. We also know that it's complex, and it also is difficult to maintain. But if we are able to lose weight, and we're looking at about 5% of body weight loss to start getting a significant clinically important difference, and then ideally that still tracks up in proportion, up 10%, 12% of body weight, you still get a very good decrease in the progression and the symptoms. Over the 12%, it starts to tail off a bit with regards to that proportional relationship. So you are looking at losing, so if you weighed 100 kilos, for example, you're looking at losing 5 kilos to start to really notice a difference just because of the weight loss on the osteoarthritis. Now, there are some slight joint differences here. This is best seen in the knee. So the weight loss most affects the knee symptoms. It's less related in the hip. You don't get so much of the reduced progression and the reduced symptoms in the hip. and then the other joints are all roughly the same. So the ankle, the big toe, the shoulder, and the thumb, they all seem to be somewhere in between the knee and the hip. So the knee, you get the best outcomes. The hip, you get the worst outcomes, and then all the others are roughly in between there. And I think, and this is between a combination, again, it's this decreased systemic inflammation. It's going to reduce the risk and the progression, and then the symptoms as well. And then, of course, the weight through the weight-bearing joints, once symptomatic, that will reduce those kinds of symptoms as well, just because you're not putting so much pressure through the symptomatic joint. The opposite obviously being true. If you had a really painful knee and then you wore a backpack with 10 kilos in it, you would expect your symptoms to be increased. And so the opposite is true as well, where we're going to see those symptoms reduced quite nicely. So that really is probably the most effective if we can manage it and it's appropriate. Obviously, if you've got somebody who is of a low body weight, then they don't want to be losing any more body weight. I've termed this one other stuff, so I'm including pretty much everything in here that we might do to a patient. So I'm including massage, acupuncture, electrotherapies, manual therapies, sort of specific manual therapies, heat, ice, anything else that you sort of apply to a patient, or that they might even apply to themselves. We do see some reasonable effects with these treatments, as in they reduce symptoms. And patients do like having them. The issue we have here is it's all very short term. Nothing in what I've just listed improves symptoms over any extended period of time. We don't really see anything out over a few days or maybe a week with improvements. So they're good for managing symptoms, or if you're trying to teach someone an improved movement or get them to do an exercise program of some kind, then it might be useful to reduce symptoms at that point. But it certainly isn't going to be anything that's going to manage the patient in the long term. Of course, those interventions the patients can apply to themselves, like ice and heat, they can be a bit more useful for managing symptoms on a day-to-day basis, because they're obviously very cheap and easily applied. They don't take too long, and especially if the patient's going through a period of increased symptoms, or they've done something that's particularly aggravated their joint, then they can use those things to bring the symptoms down. So unfortunately, because of the short-term nature, it brings in this question mark over the value of these treatments. Are they worth doing when they don't provide too much of an extended improvement? And that will, of course, again, depend on the individual, depend on the setting, depend on the resources available when you're treating the patient, and we've got to be judicious with what we use with these patients, but also making sure they understand what's going on with regards to the treatment that's being applied to them. What is actually happening at a physiological level. We're probably just interacting with the nervous system, mostly with regards to these symptoms. We might cause a small reduction in local inflammation with some of these interventions, but that's what's not particularly lasting for any period of time. As we talked about, we're really looking at systemic inflammation being the big driver of the osteoarthritis, rather than what's happening at a local level. Pharmacology, again, we can have a reasonable impact with regards to pharmacology, and we are looking at pretty much the simple analgesics are going to be what's recommended and have the most evidence base behind them actually working. Obviously, paracetamol can be useful, and topical non-steroidal anti-inflammatories seem to be the most effective, and of course they are associated with a reduced risk profile as well. So we're looking at a topical sort of diclofenac type cream, or a topical ibuprofen cream applied to the joint, and that tends to be the most effective at reducing those symptoms in the joint itself. Guidelines now are suggesting we avoid opiates. They don't seem to have will reduce pain sort of short term, but obviously the downstream effects of taking opiates over a long period of time with increased sensitivity, pain sensitivity, and obviously the addictive nature of an opiate is extremely problematic. So we're looking at, with pharmacology, we're looking at sticking to the non-steroidal anti-inflammatories, again, particularly topical, and paracetamol as needed. There will be, of course, some patients who have a flare-up of their arthritis, their osteoarthritis, who will likely need a short-term use of an opiate to get them over that increase in pain. But if we're getting that much pain from the osteoarthritis, then really we need to be making sure it's definitely just an osteoarthritic process that's occurring with a short-term flare-up. So bracing's a really interesting one. So this is something that's commonly asked about by patients. It's also commonly utilized with regards to osteoarthritis, and a lot of claims, of course, by people who make braces as to what they might do and what they might help with, and how they might work. And I've broadly split these into two types. The simple type of brace that I would talk about would be something like a neoprene sleeve that's going to provide some support to the joint. Typically you're going to use that around the knee or the ankle or the thumb. Bit difficult to use that around the hip, but we mostly will see them in the thumb and the knee and the elbow as well, I suppose. So this is your typical neoprene tight-fitting brace, and they come in various different types and with saying various different things that they might do, but really they tend to all work in the same way. They provide this sort of compression and this feeling of support that's applied to the joint, and they likely are going to work mostly on a neurological level, so essentially providing confidence in the knee that it's going to be more functional. I once described it as a hug for the knee. It's just being nice to it, giving someone that bit of support around the joint and allowing them to function a little bit better. There doesn't seem to be any difference if you apply a cheap type of brace to an expensive type of brace in that simple sort of neoprene sleeve, so we don't need to be going for these really, there can be some really quite expensive and complex with loads and loads of Velcro straps. We probably don't need to be using that. A cheap neoprene sleeve is probably a really good option. And the second type are these medial offloader braces, and these are a lot more expensive. They're created by an orthotist, they're usually bespoke, and it looks a little bit, this isn't quite an offloader brace that's in this picture, but it's close. So the idea for this is what they do is they provide a medial force, so it's sort of gapping the medial aspect of the knee joint, but also a offload distraction force, and the idea is to literally offload the medial compartment of the knee. Now, as far as I can work out with the biomechanical studies, it's not actually providing a force offload to the knee, but I think what it's doing is it's giving a very strong neurological input, and it might even cause a neuromuscular change as to how the knee is supported with regards to its muscles and the way that it functions. But I think what it's doing really is it's providing this really nice force to the knee that sort of, for want of a better phrase, changes the way that you functionally utilize the knee, and have that a lot more confidence in it. Now, again, the reviews on this across a research base are pretty unimpressive. So they don't really seem to, if you randomize people into them, they don't seem to add a lot of benefit over either a placebo brace or not using the brace at all. However, we do see patients with extremely good results from using this type of offloader brace. So it is likely that picking the right patients to use them is going to be the most effective outcome. As I mentioned, they are expensive. They're available some places on the NHS, but not all. And if someone's in private healthcare in the UK, then they'll obviously have to self-fund for the brace, and they're within the region of £500 to £750. So they are expensive, but as I mentioned, that some patients do find them extremely effective. So they're likely to be much more effective in our younger patients with specifically medial aspect osteoarthritis of the knee, and patients who want to have a high level of function. So they want to walk a lot, or they even want to run or go to the gym. They want a lot out of their knee, but also are a long way off from utilizing a surgical input. So it might well be worth trying that offloader brace in those kinds of patients, but that conversation about expense is definitely needed. What I typically do with patients who want to try the offloader brace is try a simple sleeve first. I would say a good proportion of the time clinically, I'll find that they use a neoprene sleeve, and actually that does the job. And you can get those from the chemist for 25 or 30 quid, and that if that does the job, then brilliant, and if it doesn't, they haven't really lost anything, and it might be that it does a bit but it doesn't do enough, and you can be quite confident that if something a bit more rigid might actually help a little bit more. So I'll clinically start people with a neoprene type brace just to see what happens. So onto the controversial topic of injectables. So if you don't know, this is controversial because physiotherapists about a month ago in the UK were stopped from using PRP overnight. So it's no longer legal for physiotherapists, non-medics really, to be using PRP, which was a bit of a shock to a lot of people. The injectables that we do have, there are some others on the market, but these are the most common ones. Now, saline is what would be used in as a placebo type injection, but there is discussion around whether saline is actually an active treatment. So you obviously, let's again take the knee, it's the biggest joint, the most likely one to probably be injected. You inject saline into the joint, it's going to dilute down the inflammatory processes that are going on within the joint, and I think there is at least a short-term improvement that's likely to happen from that. So I don't think saline is actually a inert placebo. It's not a true placebo, but theoretically, obviously, it's going up against these other drugs. So no one is injecting saline particularly into osteoarthritic joints for an intended benefit. We've mentioned PRP already, and I'm not going to stick on that particularly long. I don't particularly think it's common or needs to be commonplace in osteoarthritis. I think we can use hyaluronic acid more as a first line injectable, just because, again, the AHPs are still able to inject hyaluronic acid, but also it seems to, in my opinion, have a slightly more robust physiological type benefits. The idea of the hyaluronic acid is it sort of replaces some of the cushioning of the joint that's lost in osteoarthritis. So it covers the meniscal surface in the knee or the other cartilage in the other joints, provides some cushioning, and some various different preparations are theorized to last shorter or longer periods of time depending on how they're made. So I think hyaluronic acid is on the table as an injectable. I don't think PRP has so much of a place. And then, of course, we do have steroids as an injectable. The problem with steroids, we get a very good anti-inflammatory effect with steroids and very good symptom resolution. But how long does that last? The average duration of benefit for a steroid injection in osteoarthritis is about 10 weeks. But there are some problematic side effects that can occur. So we might get a chondrolytic effect where actually we can really significantly aggravate the structural change from osteoarthritis, and that can be really problematic. But it also might affect the ability of a surgeon to do an effective knee replacement as well within a certain period of time. And so some are very anti doing the knee replacement if a patient's had a recent steroid injection. So we do need to be very careful with that approach. So how would I deal with injectables? I think if you've got a patient who has very significant symptoms and are not keen on having a joint replacement in the next few months, then I think a steroid is a possible option. The easier joints to inject are obviously the knee, the ankle, the toe, the and the wrist and the thumb. The hip is obviously much more difficult to inject a steroid, but it is doable. The hyaluronic acid, I think, is worth a try. So if you've got a patient who is struggling to get into an exercise program or is really stuck on wanting some sort of intervention, something along those lines, I think hyaluronic acid does have a role. I would be careful about suggesting it as a first line treatment. I would want to go with what we've talked about already, the anti-inflammatory, topical anti-inflammatories, weight loss and an exercise program. That's where I would start. We'll talk about this in a minute. Then if patients are struggling or not improving, I think a hyaluronic acid injection is an option there. I would reserve the steroids for those patients with very severe symptoms. With regards to timescales before operations, that really depends on the orthopedic surgeon. Some are happy to do it within 6 weeks. Others would want to wait 6 months. So this is part of the risk you're running with a steroid. Is obviously if it's done outside of the orthopedic department, it's then what's going to happen in orthopedics. Injectables controversy. So finally on to surgery, and this is obviously a very effective joint replacement. Total joint replacement is very effective management for osteoarthritis. It's the duration of how long these replacements last is extremely good. You're looking at about 25 years to 30 years on average for a joint replacement, knee or hip joint replacement. So they're extremely effective. The problem is they're extremely significant surgery. So patients that are otherwise unwell are going to struggle because of the requirement to have sedation and the rehab, those kinds of things. And other joints are more tricky. So ankles especially are difficult to replace. Shoulders are somewhere in the middle, or reverse shoulder arthroplasty, and other joints are obviously very small. So the joints that you can replace are extremely effective. It's really good. However, you're not going to be offering that particularly in very young patients who are not going to want to undergo that kind of surgery. Unwell patients aren't going to want to undergo that kind of surgery. And there is a risk with regards to function. So the joint replacements do extremely well with regards to pain relief, but it's the function can often be a little bit less than desirable. These days they are looking at getting 120 to 0 range of motion in knees and really good range of motion in hips as well. But of course you do have to go through quite a lot of rehab, and the sort of protocols with regards to these surgeries is the recovery is a lot faster, so the outcomes are good, but there is obviously that risk with anything related to surgery that there is some kind of adverse outcome, so we do need to be aware of that. We're really not looking for arthroscopies as a significant portion of managing our osteoarthritis patients. None of these sort of washouts or trimming up cartilage, those kinds of things, it's really just not going to be that effective and likely actually probably just accelerate the osteoarthritis. There is going to be a small cohort of patients that will benefit from an arthroscopy, but we're talking single-digit percentages with regards to them being much younger, much more active type patients who don't want a joint replacement but are really struggling with pain. There is going to be that small role, but it's like I say, it's going to be minimal. It's going to be on quite lengthy discussion with a surgeon about the pros and the cons, and the patient understanding that it really it's a difficult call with regards to what you're going to do there. As I said, you're likely to actually escalate or increase the risk of that osteoarthritis deteriorating. So it might be that kind of short-term gain, long-term loss with regards to arthroscopies. And some patients will be happy with that, but most patients that's not going to be particularly an option. So we're going to talk a little bit about decision making, about just about on time here, and this really centers around how are we going to apply some of these different interventions to individuals. So we obviously have these big RCT type papers which tell us, you know, exercise so on has some benefit, but is it that beneficial? We've talked about injectables, we've talked about surgery. And obviously everybody is an individual and everybody's different. So my decision making centers around basically with regards to these 5 factors. So younger patients compared to older patients, if patients are older and they've got significant symptoms from their osteoarthritis, a joint replacement is not a bad option, even quite early on. If they are particularly keen on having a joint replacement, then they are going to get pretty good outcome. If they're over 75 or over 70 even, the joint replacement is likely to outlast them. So the need for revision is quite low. And this is in knees, shoulders, hips with regards to joint replacements. Whereas younger patients, we're really looking to try and avoid it. If patients are older and they don't want a joint replacement, then there is good evidence that changing these other interventions means that they can avoid joint replacements as well. They aren't a necessity, or they aren't an inevitability. So there is good options there, but it's certainly, when the patient is older, I'm more likely to send them off to a surgeon, whereas when they're younger, I'm much less likely to do that. With the younger patients, I'm more likely to employ more aggressive type interventions. I'm more likely to consider something like a hyaluronic acid and a medial offloader brace to really try to get that function and those pain levels down, to give them more a quicker return to things like work and hobbies, whereas with older patients, a little bit more likely to err on using something like a neoprene sleeve exercise, that kind of thing, to try to return the joint to improved function. Pain levels are really important. So if patients have an extreme level of pain, then I'm more likely to get them to go towards an intervention. So think about what we talked about briefly with regards to the Lancet review. How much benefit is the exercise going to have on the symptoms of the osteoarthritis? And probably not a great deal. Whereas we know if we're introducing something pharmacological, we can be much more effective with regards to reducing pain. So that topical non-steroidal anti-inflammatory, maybe a hyaluronic acid injection, or if it's very extreme pain, then a steroid injection again is an option. Whereas if they've got low levels of pain but their function is poor, then I'm much more likely then to go towards using the exercise to really try and improve the function of the knee or the joint, and try to improve them in that way. And the same with this functional deficit. So if the patient has minimal they can do everything they want to, it just hurts, then again you're less likely to get a really good effect from exercise, whereas you're much more likely to get improvements with specific exercises as well, if they've got reduced function. So that would be strength or range of motion or a particular activity they're trying to do, especially if they've got a flexion deformity or loss of extension or strength. You're really going to have a better likelihood of a good outcome if they've got those functional deficits. Night pain is a real indicator that we need to do something interventional, and certainly if patients have a lot of night pain, then joint replacements are again a very good option. but also can be something that we might discuss differential diagnosis around. And then general health is something else that I'm going to really try to interact with. So we know that things like smoking, alcohol intake, we've talked about abdominal fat, and related to those things, your diet have a big impact on symptoms, but they're also going to have a big impact on recovery from some of these interventions. So really try to work with patients if they've got a poorer level of general health, try to improve that as much as possible to get better outcomes. Basically, we talked about weight loss and how that has a good impact, and so if patients have those in inverted commas modifiable issues, then really trying to work on those and modify them to see what the outcomes are before we move towards interventions. Because if you have an injection in your joint but you've still got high levels of systemic inflammation, it's not going to last very long and you're going to be back to square one. And equally, the exercises isn't really going to do that much if you're still got a poor level of systemic inflammation floating around the body. So combining those things together can help you with your decision making on how you might treat the individual in front of you. Now, I said I was going to stick my neck above the parapet, so there's a big picture of me, and this is how I would hierarchy the treatments currently for osteoarthritis. So this is what I would look at trying to utilize in individuals. And obviously we might bring some of these onto the table or remove them from the table depending on the individual themselves. So the most likely thing to give you the biggest outcome is going to be weight loss. So as we discussed, that doesn't necessarily mean it's easy, but comparative to the work that we're going to have to put in with the rest of it, that is going to give you the biggest outcomes if the patient can lose weight. That's going to be followed by non-steroidals, particularly the topical kind. So that's going to give you the quick reduction in symptoms that you might be looking for, obviously with the caveat that the patients need to be able to take non-steroidal anti-inflammatories, but that's going to give you a short-term improvement in symptoms with minimal intervention. Then we're moving on to exercise, and this is where we really need to start picking the patients a little bit more specifically. So as we talked about, for the patients that I think are going to improve the most with exercise, we're looking at functional deficits, so either strength or range of motion, or a particular activity, climbing the stairs, etc. We're looking for that real functional deficit. We're not looking at basing that around pain levels particularly. Bracing, we're going to bring bracing in, and that's something we can potentially use with everybody, but again we're looking at the younger patients and patients who want more out of their knee, so they're younger, more active, and the type of bracing that we're going to use, I'm going to go for a neoprene type sleeve to begin with, and then bring in potentially a medial offloader brace in the knee, or something more intense if that doesn't work, relating to their financial situation and what can be provided as well. Then I'm going to move on to a conversation about injectables, and that usually for me, the injectables come down the line after we've looked at weight loss, non-steroidals, exercise and bracing. So we're talking 12 weeks at least before we even start discussing injectables, unless the patient has extremely high pain levels and we need to try and get those down. There are some other slight possible variations with regards to it affecting their work, and they need that reduction in symptoms more quickly, then that's possible, but still I do push that down the hierarchy currently. And then finally, surgery. It's very effective, but I want to try and keep patients away from that surgical option as best as possible. And again, the only slight caveat to that is the older patients who are keen on a joint replacement, then I'm happy for them to have that conversation with a surgeon, because it is an extremely good outcome. But equally, it's not an inevitability. There is good using the combination of the interventions above, then we are quite often able to avoid that surgical input. So we come to the end of the sort of written content, I suppose, for this this osteoarthritis presentation. Hopefully below me here you'll see a couple of banners, so that's got the code in it for you for attending. So if you want to get anything from my shop, then you can go there and use that code, and that'll get you 20% off anything in the shop, but it also will get you 20% off my online recorded course. So that covers everything with regards to rheumatology. I do it from an MSK perspective, so it starts at an introduction to rheumatology. We cover the conditions. We also discuss recognition of all the rheumatology conditions, and then management as well from both a pharmacological and non-pharmacological point of view. That currently runs, I think, to about 14 hours of content. I'm just in the middle of upgrading it, so it will run a little bit longer than that as well. And if you do enroll in that in the next 24 hours, then the osteoarthritis book will come free with that course as well. So that's the most comprehensive course that I do. I do have some online courses and in-person courses, and you can find those on the website as well. So I've been Jack. I do class myself as a rheumatology specialist. You can find me on all the social medias. I'm guessing that's pretty much where you probably found this webinar, but do follow me as well, and my YouTube channel as well. If you just type rheumatology physio into YouTube, I'm trying some new types of content on there as well for learning too. So we're going to head to the Q&A section, and I can see that there are a lot of questions, so I'm going to get through as many as we can here. So the first question at the top, regarding weight loss, any idea as to what aspect of weight loss may have influenced the improvement, e.g. cutting out processed foods and sugars? Yeah, so this is a really interesting point, because we're talking about this systemic inflammation and the complex nature of increased body weight. Then it's difficult to know the components. So is it, as you've said, is it the direct improvement in diet that reduces the systemic inflammation? Is it the reduced, particularly abdominal fat, not producing adipokines, which stimulate the inflammatory system to run at a higher level? And then patients who have the symptoms, the literal reduced stress through the individual joints. I suspect that it will be a combination of all of the above, and likely depends on the nature of, you might have some patients who are not necessarily eating a lot of junk food, but are eating far too much food. Those patients do exist, but we're definitely looking at trying to have a comprehensive approach to weight loss, so increased activity levels and improved diet, so we can try and hit all of those targets. Regarding arthroscopy, few patients who have had meniscal symptoms, but where it's clearly on a background of osteoarthritis, usually in the 45 to 50 age group, and are almost always active. What are your thoughts on arthroscopies in this cohort? Yeah, so I would agree with you. So there are patients who they've got that sort of degenerative meniscal tear, and they probably get not true mechanical symptoms. They're not truly locked. They're not truly giving way, but they've got that big click, clunk, or feelings of giving way. And it can be tempting for the arthroscopy at that point. I think the problem is that we are seeing, it's quite obvious that arthroscopies, particularly meniscal interventions, not the repairs, but the removal of tears, for example, have been significantly implicated in increased risk of developing osteoarthritis. So I'm still hesitant on those. The age group there is important. You've mentioned sort of 45 to 50. So they're going to want a lot out of the knee, and it's going to need to last quite a long time. But my most recent understanding is the surgeons are very confident in those replacements, and the rehab, as long as the rehab is sufficient, you can really make some significant improvements. So I think that's a really individual pro and con discussion. Like I said, there will be some patients who benefit from the arthroscopy. I would suggest they're probably on the younger age, so we're looking probably 30 to 35. We're probably looking at those kinds of patients really, who I'd be more confident referring through to orthopedics. But of course, you can always get the advice from orthopedics on what's going on there. Okay, we've got this. What advice do we offer for osteoarthritic PIP joints to prevent deformation? Do passive stretch or does weight reduction have any effect? So we're not going to prevent, if the deformation is going to happen, we're not really going to prevent it, which is really unfortunate. There used to be this theory. I worked with occupational therapists, and there was this theory about avoiding stress through the PIP joint might reduce the deformation, but I haven't ever seen that actually sort of proven. The thing that we want to really do, I suppose, is with the PIP joint specifically, it's either going to be related to their manual job, or it's going to be related to their systemic inflammation. So the weight reduction is going to help with systemic inflammation, but it's obviously not going to help with the weight bearing aspect of it. So, it's difficult in patients with that kind of occupation. They're not usually able to move to a different type of occupation, so they stop stressing the PIP joints so much. There are some really good little sleeves that go over the fingers. They can be really good to give some of that sort of support, but also to stop knocking, especially if they've got nodes, to stop that pain. Here's a good question. What happened to high tibial osteotomy surgery? Haven't seen it around for years. Essentially, they've really reduced the numbers that they were doing because it's not delaying the knee replacements by very long. So I think they were only averaging 3 to 5 years delay, and that was because they were telling patients that their knee replacement would last 10 to 15 years. But now the knee replacement's lasting 25 to 30 years. It's just not necessary. They just replace those knees now. When to consider the steroid injection, as patients expect quick results, they fail to follow the exercise. So the problem, like I said, the problem with the steroid injections is the possible downsides, the accelerated use of accelerated progression of the osteoarthritis. There's obviously a possibility of infections, those kinds of things. So I'm really pushed the steroid injections down the list. You mentioned here again hyaluronic acid. That's something its safety profile is better, so I think it's probably worth a go with the hyaluronic acid to reduce the symptoms if they've got significant symptoms. And then the steroids I would reserve for people who have high levels of symptoms. So that we talked about night pain, but also just high levels of pain that I'm proving. I would then consider the steroid injection, but I certainly, in my personal experiences, I would be considering that within an MDT discussion. So I'd probably get orthopedics involved, or a maybe sports and exercise medicine consultant to discuss alternatives before going forward with a steroid injection, just because the duration, average about 10 weeks, and the likelihood of a bad outcome is higher than we would like it to be. What's the rationale behind trying a neoprene brace before an unloader style? What would be the outcome of trying a neoprene brace inform the decision to try an unloader brace? So so the reason that I try it's the cost thing, but also because the unloader brace, as far as I can work out, they're not truly unloading the knee. So the forces that are going through the knee are not actually unloads, they're not less. So it's basically like a stronger hug for the joint than the neoprene one. So there's no, in my opinion, there's no harm trying the neoprene brace. So you've got to think about the process of getting one of these unloaders. You've got to have another referral through to an orthotist. They've got to do the measurements. They've got to make it and then deliver it. So in that period of time, going and getting a £30 neoprene brace, that might be sufficient to get you into an exercise program or increased activity, whatever it might be. So to be honest, it's a lot process based as it is anything else, because you can just go and get one and it might be enough to sort someone out. For exercise, what about the GLAD program? Good evidence for NEOA. So the GLAD program is so the GLAD program seemed to be quite good, but then as I mentioned, this Lancet reviews included the evidence with regards to GLAD, and I don't think it stacks up particularly comparative to any other type of exercise program. It's certainly not significantly better than any other type of exercise program. So currently I'm erring on individualized exercise programs or group exercise programs of whatever flavor is available locally. Many patients are unable to use non-steroidals. Do you have a go-to alternative? So without non-steroidals, then if you're completely unable to use them, then that is problematic. So paracetamol is the next option, and then that might bring in the sort of hyaluronic acid discussion earlier into their sort of management process. Regarding age and joint replacement for a knee, do you feel there's a minimum ideal age? I think that's probably a question for orthopedics and the surgeon on an individual basis. What you will see in the younger patients is high levels of symptoms, but the radiographic change is not there. Where I usually will say that I wouldn't base surgical referring to a surgeon decisions based on imaging. However, I would say that in younger patients, so prior probably to 50, I would be thinking at least seeing sort of moderate change on imaging, but also related to pain as well. So they will replace knees at any age. They do it for trauma reasons, and they do last for a long time. So there probably isn't a minimum age, but really I'm starting to lower my threshold for referral at around 50. Time we on? We've got time for a couple more. This is a nice question. Have I got any idea why there is an impact on symptoms on knee-OA and not hip-OA? So I'm guessing we're talking about weight loss here. My guess would be it's related to the structure of the joint itself. So obviously the hip joint sitting as a ball and socket, deep ball and socket joint comparative to the knee being that hinge. So what you're going to get in hip joint degradation is you've got a lot of surface areas. You've got all of that socket, but also all of the ball, and you have this difference. Obviously, when you're weight bearing through the knee, then you typically end up weight bearing through the medial aspect of the knee. So the actual structural force that's going through the knee is more directed to a specific location, whereas in the hip it's more widespread. So I think that's probably why you don't get so much of an improvement in hip osteoarthritis. You will still get an improvement, it's just lower. So you're probably more looking at the systemic impact rather than the actual force reduction. Any thoughts on evidence for gait aids or like walking sticks? totally, I didn't mention them in this. It's not really an intervention, is it, in the same way, but certainly very useful for some people. Again, it can be a good crutch, I suppose, to use a pun, really, but it's good for increasing confidence, especially if they've got feelings like they might give way, and obviously you can use it to weight bear through the upper limb rather than through the joint. Particularly, I would use them for flare-up periods rather than long-term management if possible. But definitely an option if people are struggling. With regards to the offloader braces, how long in my experience do people find the offloader braces useful for? Months or years? Well, they're not that old, these offloader braces. They're a bit newer to the market, so I don't know if we've really got that information. Clinically, I've found that people that find them useful, they go on to find them useful for an extended period of time. They tend to, what the process tends to be with these people that do find it effective, is they will have all these pain and these symptoms sort of day to day, and then they start using the offloader brace quite regularly. And then what they do is, as they get back to their activities, they find that they could use them less, and then they can just use them for aggravating activities. So a few patients who only use them to go to the gym, or they only use them if they're going for an extended period of time walking or standing, so they don't use them sort of constantly, if that makes sense. So they and that might be a bit of practice as well. They find what is the most effective situation for them to use them, and then they do tend to do quite well. But I couldn't give you a specific answer there. Got a point here. Can get lateral offloaders as well. Also in Canada, spring loader tri-compartmental is being trialed. I've not seen that one yet. You need to get a mortgage to buy one. Yeah, I can imagine that is expensive. Unicompartmental OA is the guide. Yeah, so I'd agree with that. Is the ones that I'm most familiar with and have found that patients find useful is the medial ones, and you can see that sort of likelihood where you're getting that medial sort of pressure to try and offload. And then final question is about weight loss strategies, and I'm not going to be able to really sort of discuss those specifically. It's not my area of expertise, but basically you're going to, if the patient is really struggling with weight loss, some people, you mention weight loss to them, and there's options they can do. They can cut back on things like sugary drinks and cakes and those kinds of things. But if patients are genuinely struggling, then utilizing psychology and the dietitians is going to be your best bet to help make that sustained long change, which is what we need. So it's a bit difficult to suggest specific weight loss strategies, really. Brilliant. So I'm going to bring that to the end. Thank you very much to all of you for spending this time with me this evening. And hopefully you found that useful. I'm going to put the recording up on my YouTube channel probably tomorrow, and I'll put that up for about a week. So if you do want to revisit this, then you will be able to do that. Please do go and check out the rest of my website. There's lots of resources on there from, as I mentioned, there's some free stuff like this video, but there's also my courses as well, and hopefully you find those useful, especially if you see patients in MSK prior to sort of medical assessment as well. So hopefully you all have a good rest of the evening. I'm going to end the webinar there. Thank you all for attending. It's been an absolute pleasure, and all your questions, etc. And the ones that I didn't get to, I'm going to try and get to answer across social media as well. So have a good rest of the evening, everybody.